with more and more deaths occurring in the fitness community, something definitely has to be done. We don't understand exactly what's going on. There's no question that it's a multifactorial scenario, but we certainly understand that when people utilize performance-enhancing drugs, including steroids, that there's going to be risks. There will be risks, and we've known this for decades. So today I'd like to present what I like to call harm reduction strategies for everyone. And always the most important strategy is not to do steroids at all. Just don't get involved in it whatsoever. Beyond that, it becomes a stepward and a progressive scenario that people start off using some PEDs, obviously, and then it progresses more and more because they work, and it's very complicated. So let's move right into this. Number one, I think physicians, healthcare providers have a duty to be ethical and to care for people, and that's my goal, and that's the scope of what I've done for the last 20 years as I present information to people that may be suffering, and the suffering doesn't matter, it's just mitigating suffering. So this is harm reduction for people that are on steroids, obviously. So let's try to keep it very simple. I'd like to keep it simple. So I have a framework for you guys. This is going to be actionable information that you can work on with yourself and your caregivers. I call it the ABCDs. This is something that I want you to write down right now. I'd like you to bring this video to your healthcare provider. I'm going to make it very simple. Let's start off with A. So A is going to represent hemoglobin A1c. It's for anyone that's getting older that has non-optimal glycemic index, prediabetes. Did you know that up to half of this country in America is pre-diabetic now? Just the nature of the beast. So if you look at this from a perspective of public health epidemiological data, there's going to be a lot of disease here that is going to add up and cause early death and suffering. It's coronary artery, it's heart disease death. So most bodybuilders and young people that do steroids, the A here is really not so relevant. But as you get older into your 40s and beyond, even in your 30s, depending on your genetics and depending on your glycemic caloric load, your activity, not to mention drugs like human growth hormone and things, and steroids, you have to understand your glycemic index. So hemoglobin A1c, internal medicine doctors, primary care doctors, this is stuff they check on a comprehensive metabolic panel or a basic metabolic panel. Hemoglobin A1c is an individual test. It represents what your sugar values have been on average in the last 90 to 120 days. So you want to understand this A based on your genetics, based on your carbohydrate load. Again, get your hemoglobin A1c, get your fasting glucose on a comprehensive metabolic panel or a basic metabolic panel, or just order glucose itself. These are all going to be labs. At-home labs are there. You guys can do this all yourself. Let's move on to B. This is going to be more relevant now because I think most people don't have the A yet. But if you get older, as you get older, the A in the glycemic index, this is going to creep up because as you get older, the impaired fasting glucotic syndrome, if you will, or pre-diabetic state heading towards type 2 diabetes just gets worse because you get older and things just change. And when you're young, you're super strong and your body's resilient. And as the cells get older, obviously they lose their potential to protect you, and people get hypertensive, they get diabetic, things change. So B is for blood pressure. B is blood pressure. Now, blood pressure when you're on steroids is definitely a concern, even for young people. But when you're young, you can be walking around for years with or without steroids, and you could be frankly hypertensive, even significantly hypertensive, and it's completely asymptomatic. It's called the silent killer. So depending, again, on your genetics, on your salt intake, on your other medical comorbidities, your other issues that you have, and the amount of steroids you're taking, even on some TRT, even on just testosterone replacement, 100 milligrams a week, this can push a man over into hypertension. So you want to measure your blood pressure. You'll see the videos I've done showing you at home how to measure your own blood pressure. I don't like those electronic cuffs. Certainly never do the wrist one. If you do an electronic cuff, make sure it's accurate and try to calibrate it with a real monitor itself, having someone check your blood pressure. So back to the B and the blood pressure. When you're young, you want your blood pressure to be optimal, which is less than 120 and less than 80. Really 120 over 80, or more like getting into the 120s up to 130 over mid and upper 80s for diastolic blood pressure. It's not optimal. You're having disease of the endothelial tissue already. And it's a slippery slope. It's silent, and it will destroy your heart and your cardiovascular system. You could see that all these pieces and these moons just line up together, and that's what we're working on here, A, B, C, D. Back to the blood pressure. So actionable information. Check your blood pressure, both arms, seated. You want to make sure it's accurate in the morning. Maybe you want to also do it in the afternoon, at night. You want to make sure it's accurately and measured, and you monitor that. Write this down. Now, treating blood pressure and harm reduction is going to be tricky. Do you give a blessing to the steroids, taking a lot of steroids, polypharmacy steroids and PEDs, and then throw in a blood pressure medicine? This is going to be tricky. So in my opinion, these harm reduction strategies are best utilized for a man that's kept the steroids down, he's on TRT, he's on the lowest dose, and he just wants to live a great life and minimize all these risks. Because just getting older without steroids, people have strokes and heart attack. You see, that's because of the ABCDs. So this is my approach. So keeping the testosterone down low, check the blood pressure, and then if you need, of course, you're going to do high intensity interval cardio, keep the salt down. Less than 1,500 milligrams a day is what's recommended from the American Heart Association, American College of Cardiology, and stroke experts as well. So keep your blood pressure down with behavior, fruits and vegetables, activity, keep your weight down, keep the salt down. If it doesn't work, you're on the lowest dose of testosterone. You can safely, in my opinion, with a great healthcare provider, use an ACE or A or B. There's calcium channel blockers. There's diuretics. Thiazide diuretics are the type of diuretics that are used for blood pressure, not Lasix and not other types of diuretics. That's not for blood pressure. Cardioselective beta blockers like Nebivolol. There's other drugs, but these are the main classes. Now, you have to understand from a hypertension internal medicine expert perspective that the type of man, who you are from your medical history, your family history, if you're Caucasian versus African American, these drugs will work differently for you. So it's very important to understand with your patient profile exactly who you are. That's that good history and physical. That's that H&P that I'm offering you guys on my app, anabolicdocapp.com, because obviously I'm limited taking patients. So blood pressure. Really want to keep your blood pressure when you're young, less than 120 on the top, less than 80 on the bottom, with or without some of these doses of medicines. For an example, I use an ARB, telmisartan, and Nebivolol. And it works wonderfully. Blood pressure for me is going to be 114 over 78, pretty much 24/7. Again, my diet's tight. I try to keep sodium down. I try to keep my weight down. I do the interval cardio, and I add these meds because I'm 58 and I want to live to 110. So the average forces, the vector forces that are on your endothelial tissue, there's nothing more important, guys. Let's move on to C. This is going to be cardiac, cholesterol, coronary artery calcium score. That's what C stands for. Okay, we're into the heart directly. You want to check a lipid panel. That's a general lipid panel. You can get an advanced lipid panel looking for advanced atherogenic markers like Lp(a) and apolipoprotein B, but you really want to start with the basic stuff first. You know, the total cholesterol, the HDL, the LDL, triglycerides. Okay, you want to get a calcium score. Calcium scores are being widely used now in primary care. There's tons of data for it now from the experts in the world that are conservative. The calcium score will show you if you have atherosclerosis with hard plaque, the disease starting. It doesn't show us the soft plaque. We can't see it. Soft plaque is the dangerous plaque. So you're going to want to follow my information, go see other experts. Again, to put it together, do you need to treat this to minimize this plaque that's hardened moving on where it becomes a prediction? It's a gross predictive model looking at all the other risks you have to stabilize this plaque that you have that's hard. Where there's smoke, there's fire, could be soft plaque. You want to stop it from progressing. You see? This is what it is. So that's the lipid. There's no data that really supports exactly what diet you should have, from even a carnivore diet straight to keto diets. So I stay away from that. But there's no question that the LDL, the bad cholesterol, is going to be a culprit. In the end, when you have heart disease, we try to keep it very, very low. So my thought is keep the LDLs low from the get-go. Diet and exercise, obviously, are going to be important. Genetics, if you have early family history, if your dad has had a heart attack in anything less than his 70s into the 50s and 40s, without doubt, this is going to be you, where the calcium score in your 30s and 40s, you'll see the beginning of atherosclerosis. Wow, that's an opportunity for you to stop this process right in its tracks with these ABCDs. Okay, back to the C. Get a lipid panel, a basic lipid panel, understand your numbers with who you are and what age, your calcium score, 0, non-zero. If it's a high number, you have to reach out to a lipidologist like Dr. Nolan. See the video, How to Not Have a Heart Attack, Part 1. Echocardiography. Now, that's the function of the heart in the left ventricle, looking for early aneurysms in the aortic, lower part of the aorta, congenital abnormalities like hypertrophic cardiomyopathy. You can get an electrocardiogram too. You need all this stuff done by a cardiologist or a great internist that knows how to read these things. This is using your data, guys, and finding your resources like me as your manager to direct you is why I'm here. Now, once you decide that there's an action plan, of course, diet and exercise, I agree with this, guys, but the data is very clear that even a person that has heart disease and genes for heart disease, with a great diet, not smoking, staying lean, doing the best they can, it still won't 100% stop the progression of plaque. I'm telling you. So that's why I love the medicines, statins, Zadia, Vasipa, PCSK9. You want to go see lipidology doctors. Now, I'm on all these medicines except for Zadia. I like a low-dose statin. I take it every other day. I use a statin-sparing drug. It's a PCSK9 drug. I like these drugs because carefully used with experts, they can lower the cumulative dose of statin because we know it can affect the muscles and statin-induced myalgia, but it really doesn't affect everyone that bad. And you don't really know if it's affecting you. You could check CKs, you could check your renal function, you could check all these things, but in the end, you have to understand, is it worth not taking it when so many people have heart disease, especially men early in life, that it's going to end up hurting them. Number one cause of death, remember, is heart disease still. And then you're now potentially putting on steroids. This is where the harm reduction comes into play. Again, but don't put all these drugs together just for yourself, guys. Use my app, use Dr. Nolan, use cardiology, internal medicine doctors, and your healthcare experts. Okay, that's C. D stands for, again, dad. Did your dad have heart disease? I can't tell you how often I pick up this stuff and then I do a calcium score and the man has some calcium buildup. And it's just the beginning. And it's a beautiful thing because we found it early just on seeing the family history. Did your dad, tell me your dad, mom and dad, tell me about your dad. Well, my dad had a stent or a heart attack in his 50s or 40s. If you hear 40s, I don't care if he was smoking and drinking and he lived, he didn't live like me, doc. He unfortunately was a stressful guy. He was a great guy, hopefully, but he smoked, he drank, he just didn't work out, and he had a heart attack at 45 or 48. Even if you smoke and drink, most people don't have heart attacks in their 40s. Maybe 60s, but not 40s. So again, family history, D, dad. Next thing is, for the harm reduction strategy here, if you're on androgens, there's going to be some degree of androgen-induced erythrocytosis. See the videos on all the red blood cells, guys. I have a whole playlist. You're going to build up the red blood cells. Now, is it polycythemia? Well, it really is not polycythemia unless your hemoglobin is greater than 18 grams per deciliter and a hematocrit of 54. But if you're in the high 17s or in the 52 range or 53 range for hematocrit, and you have high ferritin and iron levels, that's why you need to understand this. So androgens 100% on every man are going to increase erythrocytosis to some degree. Do you have polycythemia, which is the state of having too much red blood cells? This is definitional based on the reference range. And now, beyond that, do you have risk for deposition disease, where it looks like a secondary scenario where you have genes for hereditary hemochromatosis? We're working on this right now with other hematology doctors. It's really interesting. It's very complicated. A lot of moving parts on this. Do you have the genes for it? Because say you're a Caucasian man, an African-American man could have it too, because we know the genes are mixed from Europe. So are you responding to that androgen, and are you building up iron levels that you won't see on a CBC? You have to integrate, you have to get the ferritin and the iron panel. And then you have to look at that. Again, use my resources on the app and other doctors. This is hematology, by the way. So we've covered cardiology, internal medicine. This is hematology. You really want to look at that, because the data for polycythemia and excessive erythrocytosis from androgens is very controversial. There's no direct line connecting the dots that you're going to have a blood clot. Now, but the risk is going to be a DVT, it's venous thromboembolism, that can go to a pulmonary embolism. That's on the venous side. And then on the arterial side, hypercoagulable states, again, here we have the heart attack and the stroke. So guys, what do we see in the bodybuilding world? Most of these people are dying from early premature coronary artery disease, heart failure, and blood clotting disorders, early blood clots. Okay, so that's why understanding this together, it's so complicated. I'm doing the best I can to make it very layman terms and to be very clear for you guys and actionable. I'm letting you know exactly what to do with your caregivers. So that's why you want to check the CBC and the iron studies, including the ferritin, and your genes. Do you have genes for hereditary hemochromatosis with the family? Again, the family history. You can't have great care without a great history and physical and a family history done. That's the genetics. I call that the crystal ball. Let's move on to the last part. It's called S. So ABCDs. So the S is stands for social, because we know the data shows when people get older, when they're alone, they're isolated, they're depressed, and they don't live long. I've just realized this in my own circles with my patients and looking at life from a more spiritual side as I get older. Social. S stands for serotonin. I have so many patients that are real people. They have depression and general anxiety. It's just true. So serotonin, S is this. S kind of wraps up the ABCDs, if you will. Serotonin, depression, general anxiety disorder. It's okay to understand that you may need some medicines, antidepressants, to get through certain periods of your life. Don't try to white knuckle that. And testosterone can be an antidepressant. It can be great for anxiety, but we all know that testosterone, with all the details, with the estrogen blockers and the estrogen and everything it's about, testosterone, even testosterone replacement doses, can cause significant anxiety for people. So that's the ABCs, guys. A, B, C, D, S. Also, you want to check your prostate with an excellent urologist and get a PSA level. Urology doctor, the best for checking a prostate. If you're around 35 or 40, you want to get this done. Urinalysis, because I find many men that have used steroids for years, even only 5 or 10 years, with hypertension, protein intake, and non-steroidal anti-inflammatory drugs with different genetics. There's the family history, but it may not manifest. I see proteinuria. Guys, check the urinalysis. This is such disability I see with men that can hurt their kidneys from steroids. Not every man has the potential for it. This guy does tons of steroids. His kidneys are fine. Doc, I did a couple years of steroids, not even that much. I have kidney disease. What happened? It's genetics, guys. It's genetic. Be careful. And the last part is colonoscopy. In America, we're screening everyone now at 45, regardless of their family history. If you have family history of colon cancer or any kind of cancers of the digestive tract, you want to go see a gastroenterologist or a good internist and make sure you get this plan. Maybe an upper endoscopy too if you have bad heartburn or any dyspepsia or any kind of, GI symptoms. You want to go get this done early. And then a skin exam. It's sad when I've done all this for people, myself, for my patients, for you guys, and then we miss a melanoma. And last year I saw a man die from melanoma. It's just metastatic melanoma is no joke. That's a tough deal. So that's it, guys. A, B, C, D, S. ABCDs. I hope you really like this. I'm trying to be very focused and actionable for you guys now so you could take notes. There's a lot of information here. You may want to stop this and just do A, B, C, take the individual pieces itself and work on them. Don't do everything at once. Thank you so much, gentlemen. I really hope this helps. Let's get some comments. The comments, as I tell you guys, are always equally as important to my message and my medical information here. Thank you so much.